Today we're going to look at the guidelines for Chapter 15, which is your OB chapter. In the code book, this covers conditions of pregnancy, childbirth, and puerperia. We're going to look at some notes at the very beginning of Chapter 15. The first has to do with maternal records. Codes from this chapter are for use only on maternal records, never on the baby's records. And the codes from this chapter are for use for conditions related to or aggravated by the pregnancy, the childbirth, or the puerperium. Trimesters, they are defined at the very beginning of Chapter 15. If you can remember the numbers 14 and 28, you're going to be very close, if not correct, right on. Most of the time, the doctor just gives you a weeks. Very seldom do they talk about days. Here's some notes that are taken from the beginning of Chapter 15 in your code book. Specifically, we're looking at weeks of gestation. The coder will always use an additional code from category Z3A to identify the weeks of gestation. This code, Z3A, is found after Z36 in Chapter 21 in your code book. Category Z3A is for use only on the maternal record, and you're going to be coding first any complications before you insert the Z3A category code. And I'm making a special note there in the fifth bullet point that category Z3A is not applicable and should not be assigned for pregnancies with an abortive outcome. This guideline is in Chapter 21, so I would make a point of making yourself a note in Chapter 15 because it is applicable in Chapter 15. There are excludes 1 and excludes 2 notes at the beginning of Chapter 15 that we need to pay attention to. Excludes 1 tells us the supervision of a normal pregnancy is going to fall under the Z34 category code. You will not be using any codes from Chapter 15 if you are merely seeing mother for supervision of a normal pregnancy. The excludes 2 notes, those conditions you can have along with Chapter 15, and those would be the conditions as listed, the mental and behavioral disorders associated with the puerperium, thus F53 category, obstetrical tetanus, A34, postpartum necrosis of the pituitary gland, E23.0, and a puerperal osteomalacia, M83.0. You can have any of those along with conditions found in Chapter 15. Okay, let's start on our coding guidelines. Well, I do want to say I did not cover all of them. I recommend that you get used to reading all of the guidelines, but just for the sake of space and time, I've picked out those that are covered in previous code books and which give us examples to help us look at the guidelines. The first scenario is a bladder abscess in a pregnant patient, 25 weeks gestation. You are going to code pregnancy complicated by the abscess. There's a 5th character added to that code to indicate the trimester, and another instructional note that says use additional code to identify the organism. We are not told what the organism is in this particular scenario. Then we would code the cystitis. It tells us for a bladder abscess, we're going to code it as a cystitis specified type, which we've done, and then we've added the Z3A25 code. I have 2 guidelines here. One is telling you about the sequencing of the codes, and the second guideline has to do with adding that final character for the trimester. Final character for trimester is here. Pregnant patient, 21 weeks, gestation, admitted with excessive vomiting. The pathways given there as well as the codes. And it tells us in the rationale that if a trimester is not a component of a code, it's because the condition always occurs in a specific trimester or the concept of trimester is not applicable. In the ICD-10-CM classification, they break it out as before 20 weeks and after 20 weeks gestation when it comes to excessive vomiting. But some conditions, it is not specific to the trimester. Then another example of that final character for trimester that's given. Patient was admitted in labor with a pre-existing type 2 diabetes controlled by oral hypoglycemic drugs. I give you there the pathway. You notice it's delivery complicated by because the patient is in labor. If it's just a pregnancy situation, they're not in labor, it's going to be pregnancy complicated by. You follow your instructional notes to add any additional codes that you need to add. And then there's the rationale. This rationale tells us that when there is an in-childbirth option for the complication, be sure you use that in-childbirth code. And in this case, there was one for 024.12. Next guideline has to do with selection of trimester for inpatient admissions that encompass more than one trimester. In other words, you come in one trimester and then you go into the next trimester while you are an inpatient. The example that's given is a patient's admitted at 27 weeks, 6 days for hemorrhaging from a complete placenta previa, and 3 days after she was admitted, now she's at 28 weeks, 1 day, she developed gestational hypertension. So I have here the rationale of how I coded that, showing you those additional characters I added. But the biggest thing is the patient was admitted with the placenta previa with hemorrhage, so that's going to be your principal diagnosis, and it's going to capture the second trimester. And the next condition that's given, the gestational hypertension, came in her third trimester. So it is going to be given that final character of 3 for third trimester. So you've got the same patient with codes that are showing different trimesters depending on when the condition developed. Again, your guidelines are showing you how to do that. The next guideline has to do with the 7th character for fetus identification. When you have a situation where it's important that you identify the fetus when you can. Not uncommon when you have multiple gestations. They will, if anything is wrong with any of the fetus, the documentation will tell you which one when they know. This particular scenario is a maternal patient with twin gestations, identifies fetus B to be in a breech position. So that's going to be a pregnancy complicated by that breech presentation. And we add the 7th character 2, in this case, to identify fetus B or fetus 2. We needed the 5th and 6th characters of X as placeholders in order to add that 7th character as a fetus identification. Sometimes people get in the habit of thinking that the 7th character is going to always be the encounter, whether it's initial or subsequent or a sequela. You really have to go by what your category is telling you, your coding instructions. And when it comes to maternal codes, in this particular code, that 7th character has nothing to do with the encounter. The 7th character is identifying the fetus. You also see down at the bottom the rationale. If you had a single gestation, you would just use 0 as your 7th character, or if your documentation doesn't tell you enough to let you know what fetus is affected, or you can't clinically determine which fetus is affected, then you're going to also use 0 as your 7th character. This guideline for supervision of high-risk pregnancy came about because coders were questioning if they should use a complication of pregnancy code from Chapter 15 or using the 009 category. And the guideline makes it clear that the 009 category is to be used for supervision of these high-risk pregnancies only during the prenatal period. And once the patient is presented in labor or is delivering as a result of a high-risk pregnancy, then you will be assigning the complication codes from Chapter 15. If there's no complications during labor and delivery, the coder can use code 080, which is encountered for full-term, uncomplicated delivery. If the patient has absolutely any other complications, you cannot use that 080 category. The next guideline has to do when a delivery occurs. This one, the maternal patient with diet-controlled gestational diabetes admitted at 38 weeks in obstructed labor due to a footland presentation, and a cesarean was performed because of that malpresentation. And your codes are given there, where your delivery is complicated by obstructed labor due to a footland presentation. And then you also have to have a delivery complicated by your gestational diabetes, which you differentiate as diet-controlled. Your gestation are there, as well as the outcome of your delivery. This is an additional coding guideline we haven't mentioned yet, but there are directions that tell us anytime you have a birth, you have to have an outcome of delivery, even if it's a stillborn. There is a code, a Z code for stillborn delivery. There's Z code for single live born or for multiples. So it's important to pick the correct code under your outcome of delivery. You also notice in that the first guideline that's quoted, the condition that is why the patient came into the hospital is going to be your principal. So I chose the delivery complicated by the obstructed labor as the principal diagnosis. And here's a guideline. When the delivery occurs, 39 weeks gestation, maternal patient presents with hemorrhage with coagulation defect. The next day she goes into labor and she eventually delivers a single live birth by C-section due to arrested active phase of labor. Two things are going on, both addressed in our guideline. The patient's presented with the hemorrhage with coagulation defect, so that's going to be your principal diagnosis. But also you're going to add your delivery arrested active phase because you know that that was the reason why she had the cesarean. If you remember from some of our earlier podcasts, you must always have a medical necessity for why a procedure is done. And in the case of a delivery, if a cesarean is done, you have to be sure that your diagnoses are going to give medical necessity for that procedure. In this case, our documentation tells us the cesarean is due to the arrested active phase of labor, so we're going to make sure that that code is there. This is one of those examples where your principal procedure, which is your cesarean, does not necessarily match your principal diagnosis, but you can justify the way you have your codes sequenced by the guidelines. Fetal conditions affecting the management of the mother. These are codes from categories 035 and 036. Patient is seen for spotting 15 weeks into her pregnancy. The doctors suspect fetal hydrocephalus. The pregnancy is complicated by the spotting. Have it there. The 6th character 2 identifying the 2nd trimester. Remember, 14 weeks is your first trimester break-off, and then 15 weeks you're into your 2nd trimester. Then your weeks of gestation. And I have the fact that the fetal condition exists does not justify assigning a code from this series to this mother's record. In other words, it's not appropriate to use categories 035 and 036 just because you have something going on. It's the point they're trying to make in this example. HIV infection in pregnancy, childbirth, and in puerperium. A previously asymptomatic HIV patient who's 13 weeks pregnant is admitted with oral thrush. She was previously asymptomatic. Now she is symptomatic. So you're going to be using that B20 code. If this were not a pregnant patient, B20 would be your principal diagnosis because she has an HIV-related condition. But when it comes to OB, you have a specific code that tells you you're going to sequence according to Chapter 15 guidelines, which state you're going to use the pregnancy complicated by the HIV as your principal diagnosis. You're going to add your HIV B20 diagnosis, then the oral thrush, and then your weeks of gestation. And I have the guideline quoted there. You can also look back in Chapter 1's guidelines, and there is a specific guideline that points you to the Chapter 15 coding guidelines when you have a pregnant patient with HIV infection. And you also, I want to point out that once you have that B20 diagnosis, she will always carry this B20 diagnosis in future codes. You don't ever go back to being asymptomatic once you've had an HIV-related condition. The next guideline has to do with sepsis and septic shock, complicating abortion, pregnancy, childbirth, and your puerperium. Patient is seen several days after a miscarriage with sepsis, and the cultures return with methicillin-susceptible Staphylococcus aureus. A miscarriage is an abortion, like a spontaneous abortion. So it is complicated by sepsis, and that gives us the 003.87 code. There's an instructional note with that code that says use additional code to identify the infectious agent, which we know is the MSSA. And I have there the pathway for how you would get that code. And then I have the rationale. When you have a Chapter 15 code for sepsis, complicating abortion, pregnancy, childbirth, and the puerperium, a code for the specific type of infection is assigned as an additional diagnosis, meaning that abortion code is going to be your principal diagnosis, and then the cause of the infection is going to be your secondary diagnosis. Just a reminder, if you have a complete abortion, meaning all products of conception have been removed, an incomplete abortion means you have retained products of conception. Abortion is a term, at least in the ICD-10-CM, that covers both a spontaneous abortion or an induced abortion. Spontaneous being the mother's body is expelling the fetus, and of course, instrumentation to remove the fetus would be a medical or induced abortion. The next guideline has to do with poisoning, toxic effects, adverse effects, and underdosing in a pregnant patient. Most of the time when you're coding pregnancies or adverse effects, that's going to be your principal. That T code is going to be your principal diagnosis. Not so in a pregnant patient. This patient is admitted with accidental carbon monoxide poisoning from a gas heating implement, and the patient's 18 weeks pregnant. There is a pregnancy code complicated by poisoning that then refers you to the table of drugs and chemicals to get the T code to identify the carbon monoxide poisoning. And I chose piped gas because from our scenario, it says poisoning from a gas heating implement. Then the gas is being piped into this implement, and that's how the patient got the accidental carbon monoxide poisoning. Then, of course, you add your weeks of gestation code. And then you see that the rationale, this particular coding guideline tells you how to sequence these codes. The next guideline, uncomplicated delivery with a resolved antepartum complication. In other words, something has happened during the pregnancy, but by the time the patient delivered, it was resolved, and therefore it's not going to affect your coding. The patient presents in labor at 39 weeks and delivers a healthy newborn. The patient had abnormal glucose levels in her first trimester, which have since resolved. Because they have resolved, you're only going to code this uncomplicated delivery, an 080, as well as the outcome of delivery, the single live-born, Z37.0. The guideline tells us that code 080 can be used if the patient had a complication at some point, but that complication is not present at the time of admission. The only time you can use an 080 code is when it's uncomplicated, it's a vaginal delivery, and a single live-born. No problems at all. You can use that code. Otherwise, you would have to use a different code. Pregnancy-related complications after that 6-week period. This is a good example of how you can have things happen after the postpartum period that are related back to the pregnancy, but your documentation has to tell you that. The coder could not know that unless the doctor specifically tied the condition back to the pregnancy. In this scenario, the patient's admitted for varicose veins in her legs. She had a little boy 3 months ago. The varicose veins appeared 1 month ago. The doctor attributes the patient's pregnancy as the cause of the varicose veins, which continue to be painful and bothering the patient, and she is seeking surgical relief. So because the doctor has stated they are related, you would look under your puerperal codes and look under varicose veins, identify them as those in the legs, and that would be an 087.4 code. Again, your documentation is what's driving your selection of that code. Otherwise, you would not be coding a pregnancy-related complication for someone who had a baby 3 months ago. In our scenario, the patient was seen 2 days ago for complete spontaneous abortion. She's returning today for a UTI. The doctor did an ultrasound that showed retained products of conception. And the guideline instructs us how we might code that. The last paragraph under the rationale is what applies to us in this case. If a patient has a specific complication associated with the spontaneous abortion, in addition to retained products of conception, then you would assign the appropriate complication code in category 003 or 007 instead of the codes mentioned in the first paragraph of the rationale. I know I've gone over these quickly. There are a lot of guidelines in Chapter 15, but please review all of them in preparation for your exams and when you are coding the Chapter 15 homework. If you have any questions, post them in the discussion board. I will do my best to answer them. Thank you so much.